So let's get started. Thank you everyone who's joining us today for our October Harvard Population Mental Health Forum series. Today we are going to hear about psychosis in the global context and initial findings from the INTREPID 2 project, which I'm very excited to hear about, having talked to Dr. Morgan about INTREPID way back when it was just starting. And it's been a huge, I think a huge labor of love, but also a really important project in terms of understanding psychosis and psychotic disorders in global settings. So I'm really excited to hear about the progress they've made. A few housekeeping notes. This is going to be a presentation followed by question and answer session. You can put your questions in the Q&A box in Zoom, and then I'll pose them to the speakers. We don't have the chat feature set up so that the attendees can chat. So again, put your questions in the Q&A box. And this is being recorded, so just be aware of that. After this is done, we will post this recording on the Harvard Chan YouTube channel with captions. So that usually should be up in it takes a few days, or sometimes it could take a week, and we will let people know when that happens. So to get started, I am going to introduce all three of our panelists, and then they will do their presentation, because I think that will go more smoothly. So we have three prominent speakers today. The first is Dr. Craig Morgan, who's professor of social epidemiology and head of the Health Service and Population Research Department at the Institute of Psychiatry in King's College London. He's also co-director of the ESRC Center for Society and Mental Health. And he has been one of the lead PIs on the INTREPID project. We also have Dr. Gerard Hutchinson, who is currently the professor and unit lead in psychiatry at the School of Medicine, Faculty of Medical Sciences, in the University of the West Indies, St. Augustine. He also serves as the coordinator of the postgraduate training program in psychiatry, the St. Augustine campus, and the University Examiner in Psychiatry for 4 campuses of the UWI. And then we have Dr. Oye Gureje, who is professor of psychiatry and director of the WHO Collaborating Center for Research in Mental Health, Neurosciences, Substance Abuse in the Department of Psychiatry at the University of Ibadan in Nigeria. He is also, and this is one of his titles, Extraordinary Professor, Department of Psychiatry at Stellenbosch University in South Africa. And I'm really honored to have the three of you here today. So I think Craig will start with sharing his slides. Thank you.
Thanks very much, Kirsten. If you just give me a little second to get organized, and hopefully everyone can see the slides. Perfect. Okay. Well, thanks very much again, Kirsten. It really is wonderful to have the opportunity to talk about INTREPID, which is our international program of research on psychosis that we've been doing in 3 countries, in India, Nigeria, and Trinidad. And our presentation will be in 3 parts. So the first part, I'll provide some background and context explaining the rationale for the program and to introduce the program. And in the second and third parts, Gerard and Oye will present some initial findings from select analyses, I guess, of findings related to variations in rates of psychosis and variations in physical health and risks using cannabis use as an example. And very much hope it will be of interest, and of course, welcome comments, questions. It certainly helps to shape our thinking to hear thoughts of other people on the work that we're doing. I guess I don't think it is something that I need to convince you all of, but I think it does bear saying to begin that psychotic disorders can be devastating, often associated with considerable suffering for individuals and families over long periods of time. But they're more common than often assumed. So, for example, lifetime prevalence for all psychotic disorders of around 3%, incidence of around 20 to 30 per 100,000 person years of risk. Though, as we'll come on to, there's considerable variation in the prevalence and incidence, and indeed in all aspects of psychosis across place and by social group. The average age of onset is around 30 years old, albeit with this skewed towards younger age groups. And symptomatic outcomes are highly varied. So a substantial minority remain more or less continuously symptomatic over the long term, but many experience sustained periods of remission, and around 50% who develop a psychotic disorder actually recover symptomatically at least. Social outcomes are poor. To take one indicator, long-term follow-up studies suggest fewer than 20% sustain long-term employment. But in saying this, I think it's important to also note that discrimination toward people with a history of psychosis contributes to this, not simply or even of the disorder. And costs are vast, both direct costs of care and indirect costs of lost employment and so on, with an estimated cost in the UK alone of around 7 billion per year. But I guess more concerning still, rates of mortality are substantially higher. So this slide shows findings from a long-term 10-year follow-up of a cohort of people with a first episode psychotic disorder in the UK, in which we found that mortality rates are around 3 to 4 times higher than for the general population. And it's been estimated that those with a psychotic disorder die up to 20 years earlier than expected on average. So psychoses are a substantial public health issue of substantial public health importance. However, there are striking global inequities in our knowledge of and our treatment of psychotic disorders. Over 80% of the world's population lives in the global south, but less than 10% of research on psychotic disorders is done in these settings. And with select exceptions, the movement for and the upsurge of interest in global mental health has largely ignored psychoses. And in fact, the last major multi-country study of psychoses that included sites in the global south, the WHO 10-country study, was set up almost 40 years ago in the 1980s. Findings from this study shaped our understanding of core aspects of psychosis for a generation. And by way of further background to INTREPID, I think it's useful to highlight 2 particularly noteworthy of these findings. So first, and this is shown in this slide, the study reported or found that there were no statistically significant differences in the estimated incidence of narrowly defined schizophrenia between the sites. And of course, we can reflect on that in questions, but the main point here is that this led to the conclusion that the incidence of schizophrenia was uniform around the world, a conclusion that was, and for many years, the textbook account. And it underpinned the dominant perspective at the time, and indeed for some considerable time after that, the onset of psychosis was largely independent of environmental, certainly socio-environmental influences, such that psychotic disorders were genetic neurodevelopmental disorders. Secondly, the study reported that outcomes over a 2-year period were better in developing compared with developed countries. And again, this is shown and illustrated here, taking an extract directly from the report that was published in 1992. And this pattern was evident in longer-term follow-ups of this and other WHO-led cohorts that now form the international study of schizophrenia. Now, limitations to these data, and the interpretations have always been problematic. And in the time since, there's been shifts in our understandings of psychotic disorders. So, for example, in many studies conducted in the global north, mainly in Europe, there have been reports of marked variations in incidence by group and by place, in contrast to the WHO findings. And to give a couple of illustrative examples, this slide shows findings from a study in the UK showing that rates are higher, incidence rates are higher among some migrant and minority ethnic populations compared with majority populations. This is being replicated many times over in many different contexts. More recently, we completed a study in 17 sites in 6 countries, 5 in Europe, 1 in Brazil, and found evidence of really wide variations in incidence. There are some illustrative examples in this next slide here of the rates and the variations in rates, so that there's an accumulation of evidence of variations in incidence that's accrued over the past 10 years. And this has also contributed, I think, to a renewed interest in environmental influences on psychosis, and indeed a shift in our understanding of the onset and etiology of psychoses. And in fact, over the past 10 years, a substantial body of research has accrued supporting this, implicating aspects of urban living, inequality and exclusion, trauma, substance use, especially cannabis use, and so on in the onset and course and outcome of psychotic disorders. So in short, what has become clear is that psychotic disorders are highly heterogeneous. They're highly varied in their distribution, presentation, etiology, and outcome. However, this evidence is from high-income countries. The near absence of research in the global south in the past 40 years means that our knowledge of psychotic disorders especially of the basic epidemiology of associated risks, of course, an outcome in more diverse settings. In fact, in most of the rest of the world, is almost non-existent. So, for example, in a review that we did partly to support the development of work in INTREPID of studies since the WHO 10-country study, we were able to find only a handful of single-site studies of incidence. All were in several ways methodologically limited, and I'll come on to that. So we simply don't know whether psychoses manifest, occur, and develop in the same ways around the world. And most importantly, what this means is that we don't have robust and replicated findings on which to base the development of accessible, humane, effective services in, for example, low resource and more diverse settings. So this points, I think, to the necessity of broadening research to include more diverse contexts. And it's the context in which we established an essentially the overarching rationale for INTREPID. But in fact, INTREPID was born in Harvard. I was at Harvard in the Department of Social Medicine as a visiting fellow in 2007. And it was then that I met Alex Cohen. I think Alex is on the call and listening in. And I attended a lecture that Alex gave about the WHO 10-country study, and in particular about the finding that outcomes were better in developing countries. And Alex had for some time been critical of the study and skeptical of the findings. And soon after our conversations, Alex, along with Oye and Dr. Tara, who leads the INTREPID study in India, published a review on the scattered studies that have been conducted since the WHO study of outcomes in low and middle income countries. And this suggested a really quite different picture, one of more varied outcomes, in many instances of, on average, poorer outcomes, including high rates of mortality in many low and middle income countries. And this pointed toward a greater diversity and a need to move beyond simple and crude dichotomies of the world into developing and developed countries to examine psychoses in more diverse settings. But importantly, also highlighted several methodological challenges, most notably that of who gets selected into studies. And this matters. Most studies of incidence, and I'll come on to this a little bit more, or a first episode psychosis rely on those who present to mental health services on the assumption that most eventually present. But this may be true in high income settings with universal health coverage and free at the point of contact services, but it's certainly not true in most countries around the world, certainly not true in low resource settings. And it was from these discussions around these topics over the time that I was in Boston, and by bringing in colleagues we both worked with for some time. So Alex had worked with Oye and Dr. Tara for a period. Myself and Gerard had worked together when Gerard was in London, and this kind of sowed the seeds for INTREPID. So let me come to INTREPID then, and to say a little bit about INTREPID, the program. It's based in sites in India, near Chennai in Tamil Nadu in southern India, in Nigeria, in Ibadan, which is around about 3 hours north of Lagos, and in Trinidad in the northern part, or the northern half of the island. I can say a little bit in questions if there's interest in why it is that we particularly focused on these sites. But there've so far been two main phases of INTREPID, a substantial period of pilot and feasibility work, and a substantive program that's currently ongoing. And to return to methodological issues, a key focus of the pilot and feasibility work was on establishing systems for identifying representative samples of individuals with an untreated or first episode psychosis, essentially kind of setting up systems to detect cases to improve the robustness of what we might be able to infer from the data that we collected or the studies that we did. Before saying a little bit more about that, the inclusion criteria for the study were set and intended to mirror the inclusion criteria typical of similar studies of incidence, of risks, and of subsequent course and outcome in high-income countries. These were that the individuals are aged 18 to 64, resident in specified catchment areas at the time of detection, had psychotic symptoms or experiences in the preceding 12 months, and had never been treated with antipsychotics for more than a continuous month prior to the start of recruitment. But just to say a little bit more about detection. So typically, as noted, the usual approach to estimating incidence and constructing cohorts of first episode psychosis to rely on identifying individuals presenting to services for a first time. However, as noted, in settings where service coverage is limited, this will produce an inaccurate estimate and a biased sample. And this has indeed, I think, been true of most research to date on psychosis in low-income, low-resource settings, and a core critique of the WHO studies. So we consequently had to extend beyond what we might term the professional sector, mental health services, to what has been termed the folk, traditional and popular sectors. And this, as part of the pilot, involved extensive scoping exercises in the catchment areas to identify all health providers, including traditional spiritual healers, potential key informants, looking at pathways to care to see where it was that people sought help from, and so on, using and developing materials to facilitate communication about what we were interested in terms of kind of phenomena of psychosis. So real efforts, a substantial period of trying to establish a detection system to allow us to identify and to work with a group of people with psychosis who are more representative of the people with these disorders in the settings in which we were working. And I think to a large extent, it was the success of that pilot that enabled us, and those foundations that enabled us to get the funding to pursue the current substantive program. The aims for this current program are to describe and compare between and within the sites, the incidence, presentation, and risks for psychosis, 2-year course and outcome. Also work looking at help seeking and impacts. And as we'll talk a little bit about in this presentation, physical health problems and comparing these between and within sites. To meet these aims, the program comprises essentially a study of incidence. That's all cases with untreated psychosis in the sites, of risks, including a broad range of risks, trauma, cannabis, neurodevelopmental markers, and so on, using case control design, and of course, following the cohort of controls initially over a 2-year period. And this final slide for me shows the range and the type of data that has been collected at each point. So hopefully that gives you a bit of a sense of the background to INTREPID and the structure and form of INTREPID and the kinds of things that we're aiming to do. And I'm going to now pass on to Gerard to talk a little bit about some of the initial findings, the sample characteristics and the rates of psychosis. And Gerard, if you just let me know when.
Hi. Hello, everyone. Thanks, Craig. So, as Craig has pointed out, the study looked at 3 populations, one in India, one in Nigeria, one in Trinidad. And as this slide shows, you see the number of person years that would be the denominator in the incidence calculation. And this first slide looks at where the cases were identified, and it immediately throws up a very interesting finding. And in the 3 sites, you see that the distribution of where cases were identified varies quite a bit. So that in India, in Chennai, which the site that we're using is a predominantly rural one, there were 269 cases, but most of them were detected from the informal sector. Whereas in Nigeria, the distribution between the professional sector and the folk sector. And finally, in Trinidad, we found that almost all of the cases were detected from the professional sector, which would be the mental health services, and really few cases came from the folk or the informal sector. Again, you see there is a significant increase in the number of cases coming out of Trinidad. And of course, this could be because the mental health services there provide identification and contact. Next slide. And in comparison with other studies, the numbers collected in total here were extremely significant, and it's quite a leap from the total numbers recruited in other sites. So we feel that the findings that we will be able to discern from this large number of cases will be extremely relevant to the understanding of psychosis in global settings, and of course, particularly in these 3 sites. Next. And if we look at the characteristics of the sample, again, we see variations. In India, the mean age was 42, in Nigeria it was 35, and in Trinidad, 32. And again, this may reflect nature of the societies, Trinidad is a younger society, and again, the detection of cases through the mental health services means that the speed with which people can get to services and be recognized may be a little bit faster. The other interesting thing is that in India, females were the greater number. And the rates of untreated psychosis are much greater for the Indian sample, slightly less so for the Nigeria sample, and most of all for the Trinidad sample. And then in terms of the diagnoses themselves, we see that predominantly they were non-affective psychoses, most of them being in Trinidad again. But in India, note that there was a significant number of cases were not otherwise specified or unspecified, as well as in Nigeria. Whereas in Trinidad, most of the cases were non-affective, and Trinidad also had a significant, far more so than the other two sites, of cases diagnosed with affective. Next slide. And now we go to the incidence calculations. And you see the crude rates show quite a marked increase in the Trinidad site, rates of 58.7 as crude and 61.3 as the standardized rate for Trinidad, 20.8 and 14.5 for Nigeria. And using India as the base rate, you see that the risk of psychosis was 3 times in Trinidad and slightly less than once in Nigeria. The other interesting thing to note here is that 61.3 is very similar to the findings for London in the EUGEI study. So it suggests that the incidence of psychosis for untreated cases perhaps is similar in terms of urban, more in sites where there are more highly developed mental health services. Next. And here we look at this separating men and women. And again, you see in India, the incidence was greater, 24.2 per 100,000 compared to 17.4 per 100,000. In Nigeria, it was slightly greater for men, 14.9 to 14.1. And in Trinidad, significantly greater for men, 71.5 to 51.1. In Trinidad, and one of the reasons that Trinidad was chosen as a third site, wholly outside of my relationship with Craig and the other principal investigators, Trinidad represents a mixed society where you have 40% of the population being of African origin and 40% being of Indian origin. And this is why here we separated the incidence findings by ethnicity. And we found that the incidence in the African descended population was greater than in the Indian population, but the mixed population, which represents the other 20%, approximating that of the Indian population. Next slide. And if we look at age group, again, we see, and this reflects the slide about mean age at presentation, you see that the peak for presentation in India was in the over 40 age range, between 40 and the early 50s. In Nigeria, somewhat similar, although the variation was less steep. But again, you see the majority of cases coming in that over 40 age group. And for both women and men, although it's more pronounced in India for women. Whereas in Trinidad, the clear peak is in the younger age groups, the 18 to 30 age group. And again, this mirrors what has been found in the more developed world in London and in Europe. And the rate for women more or less remains constant. And interestingly, compared to India and Nigeria, there's a dip in the over 40 age range. The peak for women seems to be more in the 30 to 40 age range here in Trinidad, but it's a kind of gradual peak. But there's certainly a dip after 40 compared to Nigeria and India. Next slide. And this is looking more closely at the rates between ethnicities in Trinidad. So as we said, the overall rate is 61.3, and we see among Indian Trinidadians, it is 47.8, and the African Trinidadians, 88.5. And using the base rate as the Indo-Trinidadian rate, we see that African Trinidadians in the sites that we identified cases had almost a 2-time greater risk of becoming or being diagnosed with psychosis than their Indian and their mixed counterparts. Next slide. And looking at the presentation, we also looked at duration of untreated psychosis. And again, here you see that the mean is much greater for India, 7.6 years, compared to 3.2 and 3.5 in Ibadan and Trinidad. And the majority of cases being identified as psychotic in that 2 to 5 year range. So it shows that the ability to seek for reasons that we hope to be able to identify takes a much longer time in India, and this might also contribute to the higher ages in onset for both men and women compared to Trinidad. Next slide. So I'll now pass on to Oye Gureje to complete the presentation. Thank you.
Thank you very much, Gerard. And good day, everyone. As already mentioned by Craig, one other important component of INTREPID is the case control study. Selected controls from the same neighborhood as cases and match them for age and gender in this case control design. We were interested in exploring various features, especially those that have been described in the global north, to see whether they hold true in these 3 settings, but also to see what differences there might be across the 3 study sites. We've now conducted very early analysis of this data, and I'm going to be sharing with you some findings in regard to physical health and use of cannabis. But I must emphasize that these are just the beginning of the exploration of this case control design, that we really have huge amount of data, and these are really very early explorations of the data set. Next slide, Craig. So this first slide is showing differences between the sites in regards to the conditions of hypertension, diabetes, and hyperlipidemia, and report of head injury. And as it can be seen on this slide, there was a sort of very striking difference between the 3 sites in regard to hyperlipidemia. Actually, in regard to all of the conditions, where Trinidad seemed to have a much higher rate, but strikingly so for hyperlipidemia, reported head injury. So this is really striking finding in this initial exploration. Next slide. And the reverse is true for these other conditions: inflammatory protein indicative of infection, anemia, malnutrition, and infection. In all of these sites in India and Nigeria had significantly high. We're not talking about cases, significantly higher rates of these conditions than in Trinidad. You can see that 2.5 times higher for anemia and 3 times higher for malnutrition, and 1.6 times higher between Nigeria and Trinidad. Infection is report of, or is the finding from blood samples of evidence of malaria, dengue fever, chikungunya, hepatitis C, or so any presence of positive response to positive blood test is what we regard as for having infection. And you can see that is so the data for in regard to that particular variable. Those next a few slides now compare the controls with cases. One thing that is striking in this is the higher rate of hypertension among control compared with cases, both in Nigeria and India. This was something what we were not expecting in terms of the hypothesis we had set out to test. We have a much higher rate of, these are rate of hypertension that we detected through really taking the blood pressure of the respondents. Much higher rates, significantly so for controls. As we can expect, cholesterol at higher amount cases, both in Nigeria and in actually it's also much higher in India among controls. Next slide. The same was true for Trinidad. And even though the difference was not that remarkable, in the sense that, again, hypertension was much higher among controls compared with cases. Cholesterol, also much higher and among controls than cases in Trinidad. Next slide. So we look a little bit more closely at this. This slide here is showing these differences between the cases and controls in regards to inflammatory protein and malnutrition, both in Nigeria and in India. And it can be seen there that cases had much higher rate of anemia and malnutrition. And in fact, in Nigeria, the rate was almost 3 times higher among cases than control in regards to that malnutrition here we define as BMI less than 18.5, which is a standard way of defining malnutrition. Next slide. So again, in Nigeria, we did this exploration in terms of the risk factor, the odds ratio for the inflammatory protein. As you can see across all of these 3 areas, inflammatory protein, anemia, malnutrition, and the presence of indication of infection, of those infections that I mentioned before. In all of these, almost 3 times higher among cases than control. So quite a high burden of physical comorbidity among the Nigerian cases compared with control. Next slide. A little bit sold in Trinidad for inflammatory protein, anemia, and malnutrition. But surprisingly, the reverse was true for infection, in which we found higher evidence of infection of those conditions with those among controls than in cases. Now, all of these not really being significant, but still quite striking in terms of the differences between them. So the inflammatory protein, anemia, and malnutrition as expected, but infection wasn't really the way we had expected this to be. Next slide. Then we look at the use of cannabis. This slide is showing 3 different levels of use. Lifetime use, frequent use, which is weekly use, at least reported weekly use, and high involvement, which means daily use. And on this slide, the bars with borders are the ones for cases, and the bars without borders are the ones for control. And again, there was a striking difference between the sites, with Trinidad having a much higher rate of all of these free definitions of cannabis use compared with either Nigeria or India. The important thing to note here is that, in fact, in India, we were quite surprised about the low rates, and this may be an indication of where the study was conducted, and that we found this sort of very low rate of use of cannabis in our sample in India. Next slide. So then the slide is to explore further what is the pattern of this distribution across the three sites, both in terms of gender and in terms of ethnicity. In Nigeria and in India, the respondents belong to fairly, there's one ethnic group. So really, that wasn't something that was of interest to explore. But in Trinidad, and as Gerard already mentioned, we had the opportunity to look at Afro-Trinidadians, Indo-Trinidadians, and then mixed ethnic group. And the first thing that is striking here, of course, is the very high rate of use both among men and women in Trinidad compared to both Nigeria and in India, where women tend to be less likely to report use of cannabis, even lifetime use. But here we're talking about frequent use. 10% of women in a sample in Trinidad reported frequent use, and that is weekly use, and 28% among men. Now, when it comes to the ethnic distribution, again, the Afro-Trinidadians had 24% rates compared with the Indo-Trinidadian, who had only 9%. And so the rate between Afro and mixed were about the same, 24 and 25% in Trinidad. Quite a striking difference between the ethnic groups in Trinidad. The next slide is to show how these rates really relate to the what we have found in terms of prevalence of incident psychosis. We can see that there's quite some remarkable correlation between the prevalence of frequent use of cannabis and adjusted psychosis of incident psychosis in these three sites, and also following the ethnic distribution in Trinidad, so that groups that reported high frequent use of cannabis are more likely to also be found to have a higher rate of incident psychosis. It's quite striking observation that been made in the context of cannabis use. Next slide. Right, so the key messages from these three presentations really are that evidence of marked variations in psychosis across sites is quite evident in what we have presented. Rates are just not uniform. They are really quite markedly different from one side to another. Comorbid physical problems, which have been described in the global north, and are also quite consistent across the three sides, even though, again, this pattern is not the same across the three sides. We think that the impact on distribution will vary by social context, maybe so, especially since we have been able to demonstrate that for ethnic disparity, especially in Trinidad. And these all bring home the importance of global perspective on understanding and responding to psychosis, as Craig has mentioned, that it's very important to provide information in a variety of settings, and certainly in the global south, in order to aid our understanding about the risk and the outcome and the cause of psychosis in a global perspective. And next slide, and that's an opportunity to thank our research teams in the three countries who are shown on this slide. It's been an intense work over the last quite a few years, and these are the people who are delivering the products, and we would like to extend our thanks to them. Next slide is to also indicate that the template that INTREPID is providing is also being replicated now in quite a few other settings. There's quite a large study going on in the European Union, which will provide the European perspective to some of these findings. And also, remarkably, we are quite delighted that some other studies are going on in low and middle income countries, studies in South Africa, in Ethiopia, in Malawi. These are all studies that will aid us in providing a richer context to the experience of psychosis globally. And so that's an opportunity to inform the listeners about the Lancet Psychiatric Commission on Psychosis in Global Context, which is an opportunity to put all of these into the global context, in the global pattern. We are going to be working in the next several months to pull the information together and provide what might be a rich source of information on psychosis. So we expect, and I will invite you to be on the lookout, and wherever possible to also participate in some of the activities that we shall be extending to the general scientific community. Thank you very much.
Thank you. That was tremendous. And I'm excited to see the Lancet activities. That's really, to be able to pull in other studies of psychosis globally. That's incredible. So we have a lot of questions already, and I expect more. And we also have a very knowledgeable, I see a lot of recognizable names in the audience. So it's just terrific. So I'll just start going through them. So Anne Stevenson, who's actually the project director on the NeuroGap study, which is a study I'm involved in with psychosis in Africa, asked about Craig's note in the beginning of the presentation about the percent of people who recover from psychosis spectrum disorders, and wondered if you could say more about that, or if you could post a link to an article about it.
Yeah, thanks, Karistan. Absolutely. I think it comes from research, again, done mainly in Europe, where we've had long-term follow-up studies. And if you define recovery, symptomatic recovery, as being symptom-free 2 years prior to follow-up, then in the study, for example, we did in the UK, it was around about 50%, and others show this. And I think there is quite a difference. So if you take a certain kind of sample, which is mainly a kind of hospital-based sample and follow over a long time, then the outcomes appear quite poor. But if you take population-based samples, the outcomes appear better. So I can certainly post links into the chat. And if I can work out how to do it, I'll try and do it while we're live.
I'm not so agile at that, but yeah, I remember reading some papers back in the day on that, but I haven't. It's not an area I've totally kept up with, so that would be terrific. We can also identify them later and send them around. Another question was, Susan Santangelo asked that she said she may have missed that, but what criteria and instruments were used to diagnose psychosis? Were they the same for all settings, and around diagnosing cases if they were not identified by healthcare providers? Can you talk a little bit maybe more about the diagnosis? And maybe also I was thinking about how you did training, or did you, in order to, you were in all these different settings, and I know myself doing multi-site studies, getting consistency in measures and all that kind of stuff, and how they're implemented can be really challenging. So I don't know if you want to talk about that. That's part of it too. Any of you?
Yeah, I can address that. We use identical instrument in all of the sites. For the assessment of psychopathology, we use the SCAN, this structured clinical assessment for neuropsychiatry. Well, anyway, we use the same set of instruments. And in regard to training, this was really quite intensive. Apart from having training in each of the sites, we also had joint training and several reliability exercises to ensure that we were making the same kind of diagnosis and drawing the same kind of inferences from the data. So yes, there was, we tried to achieve as much of that reliability as possible across the three sites through those kind of joint exercises and joint training.
Excellent, thank you. And Craig did put the paper in the chat. Another question was, when to get nearer and had a question. It's great to see the study includes inflammatory proteins. Is there perhaps a plan for genomic, transcriptomic, and proteomic analysis? And this would be interesting given the study design. And I know you are working with folks on, I think you're working on folks on genetics, at least of some of the sites. So you want to speak about that? No one wants to.
Thanks, Garrison. Oye, I'm looking at you again, maybe to say a little bit about that. Or Gerard.
Yeah, I can speak to that if you want. Yes, the INTREPID itself is not large enough to be to provide some kind of really substantial information genetic, but we are collaborating with other studies and providing data as part of our ongoing study. And in fact, we are also going to be part of the African ancestry genetic study, which is a much larger study that's going on, especially from Nigeria. It's not all of the three sites that can take part in this because of various policy and administrative issues in terms of sharing samples. But to the extent that is possible, we are availing those other larger group the opportunity to have input from our data set.
Yeah, that's terrific, and I want to loop back to that. But I also have a question for Gerard on substance use. And what substance use scale was used, and were there any interesting findings for other types of drugs? For example, did you collect information on things like methamphetamine or khat? I don't know if khat is used in the context that you are doing INTREPID, but it's used in some of the countries we work in.
Well, the scale we used specifically for cannabis was the assist scale. So we didn't specifically look at detailed data for other drug use because the prevalence of use of those other drugs is not that great. But we did collect data in general about drug use. The other thing we've looked at in some detail is alcohol use. And we do plan to compare alcohol and cannabis use in terms of their impact on the presentations and the differences between the sites.
Interesting, yeah, so we haven't looked at any of our drug use data yet. And we do find that the prevalence of different drugs just is so context dependent. There are certain things that are used like in Ethiopia that aren't used at all in South Africa and stuff. So it's much more complicated than I first anticipated. Another attendee asked, how will these results be used to improve treatment care in these locations? And I know that's something you all care about a lot. So I don't know who wants to start. Oye, you want to start with that, or?
Yes, we can.
I know it's a big question, but.
Yeah, that's right. Thank you, Kirsten. Well, two things. The three sides are really quite different in terms of, as we can see from the presentation, the access to care. I mean, almost 95% of every case in Trinidad was accessed from the public health system. Much less so in Nigeria, but even less so in India, where most of these people had no treatment, had not access to treatment at all. So there's a whole range of opportunities for us to see how we can provide this information about how to improve care. For example, in Nigeria, it is quite clear that facilitating evidence-based treatment in traditional and faith healing homes will be an important way, because more than half of the cases that we've selected or we have identified have come through that setting. And so how can we develop some kind of collaborative work with them and to ensure that their service improved? And that would be an important thing. And in India, of course, how can we arrange it that people have early access to care? When you have this long duration of untreated psychosis, and most of these people have been evaluated outside of any kind of treatment facility, they are not seeking care. What's the responsible for that? And to what extent can we bring about some kind of or initiate some changes that will bring these people to care much earlier than the case at the moment? So these are various areas of and for Trinidad, it's quite clear that cannabis is an issue there. It's so we will to see to what extent that's also kind of be factored into some kind of preventive information and sharing of message to in the public sector.
Thank you, Oye. Going back to Trinidad, there was a question about that population and about the increased rates of psychosis in certain subpopulations in Trinidad. And I was curious too, what you think about that. Is it tied to environmental effects, and how do you think it affects treatment and diagnosis, or does it? If you wanted to talk a little bit more about that, Gerard.
Well, I think the location of the sites is a factor, because the sites are located in the northern, more urban part of the island, and the environmental effects in that part of the island would be related to urban risk factors, exposure to crime and violence, socioeconomic deprivation, and issues like that. And of course, as Oye was just saying, the findings clearly suggest that cannabis use is a big factor, and particularly for a segment of the population. So I think that one of the questions is, how do you mitigate against those risks, which to some extent are outside of the control of both the services and the people affected. So we're certainly looking at that and trying to develop ways in which we could engage with the policymakers as well as the health ministry, so that we could perhaps allow the services to evolve in a way that would address some of those issues. And in addition, to look at the kinds of collaborations that might be useful with other areas of the society, housing, the judicial and legal services, education, in order to intervene, certainly from a preventive perspective, as well as to develop services that could target specific populations or specific subpopulations.
Interesting, thank you. So two people asked a similar question, so I'll pose this. One person who asked was Dr. Manuel Mswega, who's we worked with and actually just fairly recently finished his doctorate at UCT. Anyway, he asked about whether you queried alternative and complementary therapies, especially in those with long duration of untreated psychosis. And someone else asked also about traditional healing. Did you get information about that? And did it help you, is it helping you understand how help-seeking behaviors at all?
Yes, well, part of the study design, as Craig had pointed out, included seeking information out from all those sectors. The folk sector would be like the traditional healers, the informal sector would be like churches and religious, and the alternative kind of complementary healers. So certainly in Nigeria, the folk sector was very important. And in India, the informal sector is very important. In Trinidad, while we did reach out to all of those sectors, we found that most of the people that we detected there had already or were in the process of seeking help from the public health sector. So in Trinidad, it seems like people might use both, but certainly with a greater focus on the public sector, whereas in Ibadan and Chennai, the folk in the informal sectors are more important.
Anyone else? My screenshot again. Anyone else want to comment on that? Or
yeah, we I mean, one of the areas of interest is actually to track pathway to care when there has been any kind of care received, and to see what experience people have had along that pathway. So we're doing that not just in terms of the quantitative studies that are mapping where people have been, but we are doing very extensive study on qualitative experience of the providers and the service users and their caregivers. In fact, in terms of where have they been and what has been their experience and so on and so forth. And we're not mapping treatment received at the moment, but all of this information will of course be very useful as we go forward, which we hope to do in terms of building on INTREPID 2 to try and see how we can use this information to advise and in fact to design some kind of intervention approaches that take account of existing facilities, existing ways in which people receive care. So yes, we have very rich data on that, both quantitative and qualitative, about pathway to care and experiences along the pathway.
okay, great. So you have a lot to do on that, I'm sure. That's terrific. Yeah, I understood that as one of the major questions actually initially of the project. Byron Good asked, do you have information about rapidity of onset so you can examine the relationship between rapid onset and duration of untreated psychosis as well as course and outcome? So Greg,
yeah, we do actually. So I guess in the way that it's typically being characterized, defined mode or collected information on mode of onset. So whether the onset is over a short space of time or whether it emerges kind of insidiously over a long period. And we can then relate that to DUP. I guess it's a little bit like kind of a response to a lot of the questions is we're beginning to look at the data and we don't know the answer yet, but we will find out and we will be able to report on it. So, but it is, we did some work on a sample in London, looking at DUP by mode of onset, and there does appear to be a very strong relationship. And I think that makes sense because the more insidious the disorder emerges, then the less of an abrupt break there is between prior function and experience, and so the less visible or immediately visible, and therefore the less pressure to get or to seek help, I would guess, is part of what the process is that's happening there. But we can certainly look at that. It would be especially interesting where in say, for example, India, where there's very long duration of untreated psychosis, what the relationship is there, and how many people do have a rapid onset and whether there's variations. But at the moment, we've not had a chance to have a look at it to know for sure.
thank you. We'll have to have you back maybe in another year or something, so that you can give us an update on where you've gotten with all your data. So I guess just a final question I was curious about is, I mean, I know you still have a lot more to do with what's next for the project, or if you're not thinking about that, and you know, are you all like, oh, I just want to get this done and move on, or like, what do you envision to be the next step? Or
I guess we just coincidentally, we just had a steering group meeting today, where what we focused on was what we do next. I think absolutely want to continue and feel it's important to continue, that these projects become something that are long-term and sustainable in different settings. It creates infrastructure then to address a whole range of questions. I think that the major thing is what can we do to intervene and to change things and to promote well-being amongst people who develop these kinds of problems in diverse settings. So that's certainly going to be a core feature of what we do going forward. I think I guess just one other thing to sort of mention on this is that INTREPID itself will continue with a focus on India, Nigeria, and Trinidad. But as Oye mentioned at the end, other projects are now being funded, and in part, I think, because of the template that INTREPID offers. it is, I think, it's more possible to convince funders that this kind of research is doable. And that seems to be having some tangible benefits. So, for example, the Wellcome Trust has funded 2 projects, one in Ethiopia, one in Malawi, which is to a certain extent off the back of INTREPID, and now having convinced them that this is doable research. So, so very, very much plan to continue this work and build something which is sustainable and long term.
That's terrific. I think the Ethiopia site is folks we work with as well. It's a huge depression. I think a huge depression project, right? So that's terrific. So I agree. I do think the work you've done has been, will give birth to a lot of projects beyond what you are doing. So that's really terrific. I also wanted to mention before, I know we're ending now, that we are helping to organize an Africa working group within the Psychiatric Genomics Consortium. And if people are interested in that, I'm going to put Justin's email address in the chat, because I just see a bunch of people on this call who might be interested. And we are going to be reaching out. We're not running it, but we're going to be reaching out to help kind of connect. And we are going to be in touch with you. We're going to be in touch with all of you. But if people are interested in that, I think that's another direction with INTREPID, with our project NeuroGap, showing that we can do this kind of work and collect genetic data. It's given a lot of energy to doing more projects in psychosis and psychiatric genetics in Africa. So thank you all so much. We had more questions we didn't get to. Thank you everyone who attended, and I'm excited to see where this goes. So we will have you back. So take care, and we'll connect soon. Bye-bye. Bye, everybody.
Thank you.
Bye.
Bye. Bye.